President-elect Mr. Sujivalal Dahanayaka, General Secretary Mr. Tisara D. Silva, Treasurer Mr. Ruchira Pereira, past presidents of OPA, office bearers, distinguished guest speakers, members of the Executive Council and Forum, ladies and gentlemen. I am delighted to welcome all of you to this seminar on new trends in dengue prevention and treatment organized by the Health and Nutrition Committee of the OPA. It goes without saying that dengue has become a major public health problem in Sri Lanka with a sharp rise in reported cases in recent times. In the first 2 months of this year alone, over 15,000 cases and 5 deaths have been reported in our country. Statistics indicate that there had been a significant increase in infections in recent times, highlighting the scale of the problem. In fact, last year, we had over 88,000 dengue cases and 57 deaths. Dengue is present throughout the country with sharp spikes in infection rates during 2 monsoon seasons. In fact, the majority of cases occur in summer monsoon in June and July. So with so many cases being reported already, we clearly have a very challenging time ahead of us. The highest number of cases has been reported in Colombo, Gampaha and Kalutara district in Western Province. This year there have been over 5,200 cases in Western Province. In addition, over 3,600 cases have been reported in Northern Province. So it is extremely important that particularly those who live in the Western Province take meaningful steps to combat this very serious disease. Effective mosquitoes control by destroying the breeding sites of mosquitoes has been identified as the best way to control the spread of dengue. While the authorities have to play a proactive role in destroying mosquitoes' breeding sites, all of us have an important responsibility in doing what we can do to ensure that we prevent our houses, gardens and neighborhoods from becoming breeding sites. At the same time, we must practice good habits so that our exposure to the mosquitoes should be limited, especially during daytime. This is particularly important for vulnerable groups such as pregnant women, children and people with chronic illnesses. Apart from the suffering caused to the patient, dengue has had a severe impact on our economy. Studies have indicated that it may be costing our country billions of rupees, while many dengue patients only develop mild symptoms. Others need to be hospitalized, incurring significant expenditure. So, dengue is a threat on many levels of Sri Lankans. It is my pleasure to welcome 3 very eminent experts on this subject as our guest speakers this evening, who will be able to tell us much more about the subject. Dr. Sudath Samaraweera, Director Dengue Control Program and Consultant Community Physician, Dr. Jayantha Weeraman, Consultant Pediatrician, and Dr. Sanath Hettige, Consultant in Family Medicine and Chairman, Health and Nutrition Committee of OPA. I know that we will be able to learn a great deal from your immense knowledge and dengue as well as your practical experience in combating this disease. Your insights and views will enable us to better understand what must be done to address this dangerous threat to all Sri Lankans, especially children. I would also like to welcome our moderator for this evening, the convener of the Health and Nutrition Committee, Dr. Kanti Ariratna. I am sure all of you are waiting to hear our guest speakers, after which we will go for a Q&A session where you will be able to get answers to any questions you may have. So let me now hand over proceedings to the moderator, Dr. Ariratna, and I wish you all an educational and informative seminar. Thank you very much.
Good evening. Thank you very much, Mr. Sanath Hettige, President, Organization of Professional Association for that opening remarks and the very inspirational welcome speech. The distinguished guests, ladies and gentlemen, let me first introduce Dr. Sudath Samaraweera, who is our first speaker today. Dr. Sudath Samaraweera is the director of the National Dengue Control Unit of the Ministry of Health. He is a specialist in community medicine and holds degrees of Bachelor of Medicine and Bachelor of Surgery, Master of Science in Community Medicine, and Doctor of Medicine in Community Medicine from the University of Colombo. Before his current position, Dr. Samaraweera has the work experience of the positions of Chief Epidemiologist in the Epidemiology Unit of the Ministry of Health, Director of the National Cancer Control Program, Deputy Director and the Acting Director of the National Program for Tuberculosis Control and Chest Diseases, Acting Director of the Global Fund for Fighting Against AIDS, Tuberculosis and Malaria Project of the Ministry of Health, and Acting Deputy Director General of Education, Training and Research of the Ministry of Health. He also has work experience as consultant on arboviral diseases at the Southeast Asia Regional Office of the World Health Organization. He is an honorary fellow of the College of Community Physicians in Sri Lanka and a member of College of Medical Administrators of Sri Lanka. So, President, Organization of Professional Association, President, Health and Nutrition Committee, ladies and gentlemen, you will understand that he is the most suitable professional to tell us about current global and Sri Lankan situation in dengue and new trends in prevention and control for this evening as our first speaker. I would like to cordially invite Dr. Samaraweera to conduct his presentation to this august gathering. Thank you. Over to you.
Dear President of the OPA, Mr. Sarath Gamage, Dr. Kanti Ariyatna, Chairperson of the Subcommittee of Health and Nutrition of the OPA, Dr. Sanath Hettige, and also other distinguished members in the chair, and also all the distinguished ladies and gentlemen and ladies who are here for this event. It's a great honor to be here with you and to share my knowledge and experiences with you on one of the most important diseases in our country, not only in our country, in our region, and also in the world. It's dengue. So we will go through this on an epidemiological point of view. So what is dengue? What is the history of dengue in our country? And what are the challenges we are facing, and what will happen in future, and what we can do to mitigate this important public health problem. Dengue is vector-borne viral diseases. Vector means vehicle that some organism carries from one person to other person, or one animal to other animal, and it's a viral illness that's caused by a virus. So there are two important aspects are there. There's a virus and also the carrier or the vehicle. There's a mosquito. These mosquitoes are Aedes aegypti and Aedes albopictus. Two type of Aedes mosquitoes are responsible for carrying the transmission of this virus. And the most important thing is this mosquito is the responsible for transmitting other diseases as well, that include chikungunya, Zika virus, and yellow fever virus. Out of all these 4 diseases, dengue, in Sri Lanka we are having dengue, and also chikungunya has been reported in our country. There are historical evidence or retrospective evidence of Zika infection in our country, and yellow fever, it is not reporting in our region, not in the Asian region, it is in the mainly in Africa and Latin American countries. And other thing is this virus has 4 serotypes. That means 4 different types of viruses are transmitted or circulating in the community, transmitting this disease. Those are called dengue virus 1, 2, 3 and 4. When you get an infection with one of these viruses, that is one serotype, you get lifelong immunity. That means that if you get infection with dengue virus serotype 1, you will have the immunity not to have that infection again throughout your life. But you can have that infection with other serotype. The most important thing is when you are getting this secondary infection, second time, that is can have very severe disease. Actually speaking, about 70 to 80% of the dengue infections don't have symptoms. That means that you will get the infection, but you don't have any manifestation of that. You get the infection, you are living normally, you don't know that you get infected, and there is no any recovery because that infection has passed without any knowing. But smaller proportion, that about 15 to 20 to 25% of the cases can have some clinical symptoms, and few of these can have severe diseases. Clinically, usually that you will have high grade fever, then severe headache, severe pain behind your eyes, and severe body aches and pains, nausea, that means vomitishness, and vomiting, and skin rash are some of these symptoms that you can get. And any other symptoms with viral infection like flu-like illnesses also may be dengue infection. So there is a wide range of clinical manifestation in dengue. But when you are getting this clinical manifestation, some of those cases can go into severe disease, that is where the alarming conditions, that is the dengue hemorrhagic fever, that is having hemorrhagic manifestations, that you can have hemorrhages, and also some leaking of your fluids. I think Dr. Weeraman will enlighten you about these things. And also some people will go into shock, and if you not treated properly, can end up with death. That's why it was called earlier dengue maranthika. But the good news is, if you manage properly at the right time with the right treatment, dengue is a disease that will not end up with death. Actually, the World Health Organization is today aiming at zero mortality with dengue. So when we look at the global situation, there is a marked increase of global incidence over past 2 decades, over past 20 years. Actually, from 2000 to 2019, there is a tenfold increase of the cases from 500,000 to over 5 million of cases annually reporting. In 2019, there was a large unprecedented rise of cases throughout globally, and spread in over 129 countries. Again in 2023, last year, the global community has experienced a historically high number of cases, over 5 million of cases reported, and more than 5,000 deaths has been reported in 80 countries or territories. And the 80% of these cases, that is about 4.1 million cases, were reported from the region of Americas. Actually, at the moment, the epicenter or the most active that the transmission is happening in region of Americas, that is especially in the South American countries. For example, in 2024, this year, for the first 8 weeks, that is first 2 months, in the region of Americas has reported 1.87 million cases already, with 422 deaths. Case fatality rate, that means how many people are dying out of the dengue, out of the people who are getting dengue, the percentage, it is 0.023% in this Latin America, the region of Americas. That is that although you are getting the disease, that the chance of the dying is less. Actually, that what is reporting in this 2024 is 249% increase when compared with the same period. That's the first 8 weeks in 2023, and when we compare with the average of the last 5 years, it is a 354% increase. That is a very high number of cases reporting early part of the year. So we don't know what is happening in the rest of the period of the year. So we have to be prepared. That's why in 2023, the WHO World Health Organization has declared dengue as a grade 3 emergency. That means that you will be getting multiple infections, the outbreaks in multiple sites, in multiple severity. So you will be having that you have to be prepared. All the countries has to be prepared. When you come into the region, the World Health Organization, that we go by the norms of the World Health Organization, we are having in this region, Southeast Asia region, 11 countries: Bangladesh, Bhutan, Democratic People's Republic of Korea, India, Indonesia, Maldives, Myanmar, Nepal, Sri Lanka, Thailand and Timor-Leste. Out of these 11 countries, Democratic People's Republic of Korea has not reported any dengue cases officially until now. So all other 10 countries are having the dengue at an endemic level. That means all the time that there is the risk of getting and reporting dengue cases in these countries. Out of these countries, 5 countries, including Sri Lanka, the other countries are India, Indonesia, Myanmar and Thailand, are among the 30 most high endemic countries. That we are again coming into the top of the list, but with a bad remark, that is Sri Lanka is one of the worst countries with dengue, that we are within the 30 the worst 30 countries. And in 2023, including Sri Lanka, Bangladesh, Nepal and Thailand has reported surge of cases, and we are having the statistics for Bangladesh and Thailand. Both countries has in 2023 is the ever reported highest number of cases. In Bangladesh, more than 300,000 cases with 1,705 deaths. And in Thailand, also more than 156,000 cases, but 167 deaths. Actually, that Thailand has taught us Sri Lankans also how to manage dengue, and with their training, that Sri Lankan clinicians has been able to bring down the case fatality rate in our country. That we will come into that. When you come into our country, the first confirmed case of dengue has been reported in 1962. In 1966 and 1976 to 1978, it has been proven that all the major cities are having dengue cases below the 1200 meter elevation in our country. The first dengue hemorrhagic fever outbreak was in 1989. Since then, the geographical spread of the disease, that is spreading the disease to new areas of the country, and the incidence, that is number of reporting cases, and the severity of the disease are the major concerns for us. Since 2000, there is a significant growth of the disease across the country. There is a step ladder increase of incidence over the year. That is, that baseline has been gradually increasing over the years. However, the case fatality rate, that is the number of people dying of dengue, has been markedly came down over these years. We had a major outbreak in 2004, and then in 2005, with the policy decision by the Minister of Health, has established a National Dengue Control Unit, and later it was upgraded to a directorate with annual budget allocation to work in full-fledged to control disease in the country. And one of the most important things, where some other countries don't have, is that we are having a presidential task force for dengue control and prevention, which was established in 2010. That means the highest level of political commitment for the control of the disease. So that is very much important in control of a disease like dengue. When you come into the current situation, as of the situation day before yesterday, we had more than 19,000 cases this year. Just because January we had more than 10,000 cases, because it is carrying forward the epidemic or the outbreak that we experienced in 2023. And also February, that cases has been come down to 6,000. In March up to now, 2,920 cases by now. So that means we are gradually that the cases are coming down. As the President has informed you earlier, the Colombo has reported about 21% of all the cases, Gampa almost 9% of all the cases, and also we had an outbreak in Jaffna last year. So because of that, it has been that now it is coming down, but still because of that, more than 18% cases are from Jaffna district. Western province is having more than 35% cases, and the northern province this year 21% of the cases. We are having high medical office of health areas now about 10, but we had more than 60 at the beginning of the year. Average midnight total, that means how many dengue patients are being hospitalized at the time at the midnight of a day. Now it is around average about 287 at the moment. There will be about 287 cases in all the hospitals admitted for dengue. But at the beginning of the year it was about 1,000. But there are only 7 cases, 7 deaths that reported this year. That is, case fatality rate is 0.03 in our country. This is a monthly case reporting over the from 2022 up to last month. So you can see that it is coming up and down. This is that we are having 2 outbreaks in each year, corresponding with the monsoon rains. That is, with the rains, all these breeding places are increasing, and the mosquitoes are more mosquitoes, more disease transmission. So this is the pattern this year, daily pattern. So you can see that it is coming gradually, but we know that now we will be experiencing after April, May, June, like the monsoon rains again. So we have to expect more cases and to be prepared. So this also that shows that cases coming down in this year, and this is the historical figures that you can see that how it is happening. So if you can see that I told that in 2004 there was a large outbreak. So when you are you are looking at the figure over the 20 years, you can't see it properly. But you can see that in 2003 only 4,805 cases reported, but in 2004 15,000 cases, that almost 3 times higher number of cases reported. So that is the turning point to that establishment of the National Dengue Control Program. So you can see that after that, the cases has not come to the baseline level, that it is 5,000, 11,000, 7,000, 6,000 likewise. That is the number of cases reported, average number has been gone up. So again in 2009, 35,000 cases reported. So thereafter, again annually that the number of reporting cases are high. So we had the largest outbreak in 2017 with 186,000 cases, and again in 2019 we had a upsurge, and after during the COVID, lesser number of cases reported, but again 2022 and 2023 reporting higher number of cases. The third highest number of cases were reported in 2023. But you can see that in the red line shows the case fatality rate, how many people are dying of the dengue. So we had a very high number in 2009, 0.99%, almost 1%. That means 1 per every 100 patients were dying. But now it has come down. despite of larger number of cases last year, we reported the case fatality rate only 0.07. That is the lowest rate that has been reported, thanks to the clinicians that they are managing, and also because of the thanks to the people, they are aware, they are coming for the early for the treatment. So this is again where the cases are reporting that in 2023, Western Province 45% and Colombo, Gampa, Kandy, Kalutara, Jaffna, etc. These districts are reporting higher number of cases. Then we come into the deaths. Last year we didn't have any deaths in 10 districts, but other districts has reported at least one death. And out of these deaths, most of the cases are dying during their prime age. They are that are most productive, younger age, working population. They are the people now dying of dengue. And total there were 62 cases, deaths, almost half males and half females. So that's how. When you come into this year we had the 7 cases, and out of that, only one pediatric case, that is less than 5 years, only one case. All other people are in between 20 to 40 years of age. And this is too early to comment on because only a few number of cases, but except only one male and all others are female, or that so far that among the deaths. This is about that how the dengue type dengue types are that circulating in the country. So it is also that important that deciding whether that there is an outbreak or not. And for the dengue prevention and control, what are the things available? So I have categorized into or prioritized 4 aspects: vaccination, the prevent the human and vector contact, vector control, and the clinical management. How to prevent the human vector contact? You can have the personal measures like mosquito repellents, applying mosquito repellents, and using the mosquito nets, and using protective clothes, that is a long sleeved loose clothes and light color clothes if you are wearing during the daytime and during this mosquito biting time. That will help to minimize the getting the mosquito and the human contact, that is been that means that lesser infections. When you come into the vector control, that next thing is that we have in the vector control, that one thing that we have to say is that we will coming into that. Until now we don't have a vaccine. We have vaccines, but we don't have a vaccine that can be used in public use in wider and in a large scale use for the use. Still we don't have that much of required evidence to incorporate into our systems as a preventive measure. For the dengue we don't have a drug. Actually clinicians are managing the supporting the for them their to keep their vital signs better, and that's how that they prevent the deaths that are going into the shock and die. So there is no specific treatment as an antibiotic or something antiviral medicine. So then what is available is control in the vector, that is this vehicle, to control in the vector. And this vector is a mosquito. Because of the mosquito that there's the 3/4 of their life cycle is in the water. Where this mosquito is breeding, it may be in your house or just outside your house. That actually this dengue mosquito needs only a small quantity of water and also clear water. So, but if it is not available, they will adapt to a different breeding place. So that's we have to keep in mind. Mosquito is very adaptive mosquito. So because of that, we have to also have to be very careful. But the evidence shows that if we eliminate these breeding places, that means that cases will go down. That means that we can have some sort of control if we can eliminate all these breeding places. The important thing is most of these breeding places are within our own houses or just outside our houses. There are 2 mosquitoes, their behaviors are different. This is important for us to take decisions. There's a primary vector, this is Aedes aegypti and Aedes albopictus. Primary vector means this is the most important vector to transmit the disease. And it's a multiple biter. That means that to have a one blood meal, this female mosquito will bite so many people. So, if one mosquito comes into a house, Aedes aegypti, and bite with the mosquito will come with the virus, infected virus, and may bite all the households to have one blood meal. So that means that not only one person, all the family may get infected with a one mosquito. But other mosquito, it is only a single biter that they will get the full blood meal from one person. And also the Aedes aegypti is anthropophilic. That means that they prefer to have blood meal from humans. If only the humans are not available, they will go to other animal. But Aedes albopictus is the other way. They prefer animal blood, but if it is not available, they will come and bite you. Aedes aegypti, they bite you inside the house. Albopictus mainly outdoor. But both feeds at the morning and at the dusk, early morning and the evening. So that is the most risk time. But even with the good lighting, even at the late in the night, they will come and bite you. And they can fly only up to 400 meters. Very weak mosquito, but they are causing havoc. And where they are breeding, the breeding sites are discarded items. This means that some of the things that are in your house that you have discarded and you have thrown out, and it is in your backyard, like empty buckets and other containers, etc. And also water storage items, temporary removal items like those ornaments, ponds, flower vases, refrigerator trays. Those are the things that is been that mosquito are breeding. When you come into the vector control, so most important is the integrated vector management. That is not a single method or single solution is there. So you have to have an integrated approach. So in that, most important thing is the removing the potential breeding sites, and also the sometimes environmental modification. That means that you have to remove those most important breeding places, like sometimes that this rain gutters in your roof, those are unreachable to you, can get blocked and have that mosquitoes are breeding there. So then you have to remove those things. That's why it's environmental modification. And then other thing is that there are chemicals, larvicides and the adulticides, that is that you can apply. So that is the adulticide means adult mosquito to kill the adult mosquitoes. You know that whenever that there is a dengue outbreak, media will be showing you fogging, that spreading that spraying chemicals. That evidence shows that it has only a limited use. So because of that, it should be used very judiciously. Otherwise, what will happen is that it will cause more damage to the environment rather than good. Other thing is the law enforcement. Sometimes that the people are not behaving well, so then you have to have the law enforcement. Other thing is, this is not only a health problem. This is a social problem, and also this is across multiple sectors problem. For example, construction sites is one of the most the notorious place where the dengue mosquitoes are breeding, because the constructions are hand in hand linked with water, and there are so many water collecting pools in the thing. So because of that, you have to have this construction sites has to have a different methodology or specific methodology not to have breeding places. Then you come into the fisheries. In harbors, boats are very notorious. In schools, it is, and also now actually in households, the breeding places are very much less, about 5% that evidence shows that. But when you come into the public places and also religious places, schools, it may be about, out of these places, about 20% of the places are having this high breeding places. So other thing is, the monitoring of the change in the mosquito's behavior is very much important, because the mosquito is changing its behavior even in the country, at the same time, the different places the mosquito behavior may be different. So because of that, you have to have a continuous monitoring. So when we come to there is no end to this elimination of vector-borne mosquito sources, that's the breeding places, that you have to continuously do this, and that's why that we are preaching that at least once a week spare 1 hour and to clean your environment. That you look, if you don't look, you will miss some breeding place and there will be breeders. So but you can't go on there like that. That's why that the scientists, researchers are targeting at the more innovative methods. There are several innovative methods currently going on, and even the Sri Lanka is contributing to this research. One is the Wolbachia infected Aedes mosquitoes. Wolbachia is a bacteria that is being in the environment. In most of the insects that this bacteria is naturally harboring these insects. But in mosquitoes it is not so. So if you want to infect with the Wolbachia bacteria, a mosquito, you have to do it artificially. The thing is, if the Wolbachia bacteria is in the mosquito can't replicate. The virus, dengue virus can't grow within the mosquito. So what will happen? There is a competition between the virus and this bacteria. The bacteria will win, virus will not win. So because of that, the transmission will be getting the lower. So because of that, so if you have more and more Wolbachia infected Aedes mosquitoes in your environment, disease transmission is less, and we have proven that in the Colombo Municipal Council area, in the Colombo 15 or Mattakuli area, we have done this a pilot project, and the dengue that the incidence in this area has drastically come down. So now we are planning to have this research expanded throughout the Colombo Municipal Council and some other districts in the medical officer health areas in the Colombo district. So with that results, if it is a good promising results, we can propagate or we can expand it to other areas, especially high burden districts in our country. So that is one of the good that actually this Wolbachia mosquito has been infected mosquito has been produced. It's a production of the Monash University, Australia. It is they are having a World Mosquito Program with them. There's a special non-profit organization within the university. So with that we are doing this collaboration to have this research. We hope that it will be having more better results in future. The other thing is the sterile insect technique. In agriculture field, that this has been very successfully used. That means that you are releasing sterile insects into the environment. So because of that, mating with that mainly that you are releasing male, in this case male mosquitoes, that you sterile the mosquito with irradiation, and with the irradiated these mosquitoes, then they are sterile and they will be released into the environment. So they will be mating with the wild mosquitoes. That means that the mosquitoes in the that environment naturally, and then there will be no next generation happening. So by that it will be that the mosquito population will be coming down. So that also that we have done the research in Gampa district, and it also has shown proven the success that once that we have released that these mosquitoes for about several pulses, that several occasions during over a 6 months period. After that followed up for the next 6 months has shown that almost zero level of the mosquito in that area. So it also has promising results. So we are going to expand that also and see how that will be effective in our country, and maybe that here is a control method in our country. Other thing is the spatial repellent. You know that one thing is the mosquito repellent that you are applying on your skin, but here it is like a air freshener that you are hanging in your room or hanging in your car. That is some repellent with that discharging the repellent into the environment. To hang it in your home or in your that outer area, and to see whether that it will repel the mosquitoes, that it will discourage mosquitoes to come into the area. So such a research is going on. We hope that it also will give results, but it's too early to say that it is a good method or not. But still that we are doing that. So if it is possible, so we will be able to that minimize use of chemicals for this fogging and other things, and it will be a good thing. Those are the innovative things in the dengue that we are doing. Other thing is the clinical management. I am not going to touch about that. We are having the clinical management guidelines, and our clinicians are doing better, and so because of that we are having the less case fatality rate. Dengue vaccine. At the moment we are having 2 vaccines in the market, but not in our country. The one vaccine has been developed by Sanofi Pasteur, Dengue. The thing is that this when you get this vaccine, if you are getting it for the first time without any infection previously, and then if you get the infection from naturally or from the mosquito, you will have a severe disease. So because of that, the WHO recommends to get this vaccine only if you had the dengue infection previously. So it is you have to test your blood to see whether you had previously infection, and if it is yes, you can have the vaccine. The second vaccine has been recommended by WHO last year, and that's by the Takeda. It's a Japanese vaccine, Qdenga. It has been licensed in several countries. You don't have to do that type of testing, but the WHO, World Health Organization, recommend it in the localities where the high dengue disease burden is existing, and also the high transmission risk is there, and the target age is 6 to 16 years. So it is too early for a country for us like where the case fatality rate is very low to introduce this type of vaccine. So for us it is evidence is much less, so we are waiting till the more evidence comes. So if it is good, yes, we can think of incorporating that vaccine into our immunization schedule. Other vaccine is still under development. It is developing as a collaborative project with Butantan and National Institute of Health in America, and also with Brazil. And this, even though this vaccine is effective, it will first available only in Brazil. So because of that, it will not be rightly available to or directly available to other countries in coming years. Lastly, community participation is very much important in the dengue control. Whatever you do, that if the community is not prepared to give the support, nobody will be able to control the dengue. Almost all breeding sites are within your home, within our homes, or within the close vicinity. So because of that, people has the responsibility to keep them clean. Another thing is the human behavior. So we are the people who are creating these breeding places. So we have to change our behavior. If you go to and see the knowledge, people are having the knowledge, but they are not practicing it. They are not transforming it to the behavior. So that knowledge has to be transformed into the behavior, and have to have it on our behavior, not to have this, to create this breeding places in our environment. So other thing is the environment cleaning should be a routine practice. Just like that you are brushing your teeth every day morning, that cleaning your environment at least once a week should be in your schedule. That then only that we will be able to fight this menace. And the clinical management. Clinicians are doing better, they are doing the best, and they are preventing deaths. But to prevent deaths, people should come at the right time. So that is very much important. When you are getting the disease, especially when there is an outbreak, if there is a suspected dengue, that they should come early to the health seeking, healthcare personnel, health facilities, and get the diagnosis properly, and then manage on their own or managing at home properly. Then only that we will be able to prevent deaths. So that is very much important. Other thing is some other medicines should not take on their own only on medical advices should take. Otherwise, especially the painkillers and fear that medicines that take in fever other than paracetamol can cause severe disease and end up death. So because of that, it is very much important. So this is a task of all of us. There is the responsibility to everybody in the city, every citizen to combat the disease. I think if all the people come into the same line, that the same wavelength, we will be able to control this disease in our country. Thank you.
Very much, Dr. Sudath Samaraweera, for this very inspirational and innovative talk. Actually, you touched upon that the dengue is not deadly if it is treated and managed properly. And you touched upon very important aspect, the community participation and the human behavior. It's we who have to control the disease. It's we who have to take the action. Thank you very much once again. Now let me introduce Dr. Jayantha Weeraman, our next speaker. Dr. Jayantha Weeraman is one of the senior consultant pediatrician in the country and holds a degree of Bachelor of Medicine and Bachelor of Surgery and Doctor of Medicine in Pediatrics from the University of Colombo. Other than these two degrees, he holds postgraduate diploma in child health and postgraduate diploma in family medicine, both from the University of Colombo. He joined District General Hospital Polonnaruwa as the founder pediatrician in 1988 and worked as the pediatrician in District General Hospital Mathura, Kalutara and Teaching Hospital Karapitiya. Dr. Weeraman started working for the epidemiology unit, Ministry of Health, for 10 years after his retirement and involved in teaching dengue case management for doctors and the paramedics, as he is one of the health professionals who was specially trained in the case management of dengue in overseas. During his tenure in the epidemiology unit, he had conducted a number of clinical audits and death audits on dengue. He was one of the members of the Sri Lanka expert team who visited Pakistan in 2012 to guide Pakistani counterparts on dengue case management during their severe outbreak. He was a member of National Guidelines Committee on Dengue and currently a member of the Ministry of Health's expert committee to review dengue deaths. He is a member of the College of Pediatricians in Sri Lanka and a member of Independent Medical Practitioners Association as well. So, ladies and gentlemen, you will now understand that he is the most suitable person to present the presentation due for today on dengue infection, pathophysiology, treatment and care. I am proudly inviting Dr. Weeraman to conduct his presentation to this August gathering. Over to you, Dr. Weeraman.
This is my outline of my talk. I'll be introducing you briefly, already you have been introduced. Clinical presentation and OP outdoor care, home care, and a little bit on pathophysiology of the disease and management of the severe form of the disease. BHF, actually you should know something about that, although it is managed by doctors in the hospital. And finally I'll conclude with few remarks. Now already we have mentioned that, the dengue virus belongs to this genus called Feoviridae, and we have chikungunya in our country, Zika query, and this virus has 3 structural proteins and 7 non-structural proteins. So actually we are interested in the non-structural protein, which is NS1, because that is very useful for us to make an early diagnosis. Because if you want to prevent complications, prevent death, we have to make an early diagnosis. And we have 4 serotypes already mentioned. 1, 2, 3 and 4. If you are infected with one serotype, you are immune for the rest of your life to that particular type, right? But you are not immune to the others. But you have a partial immunity because these serotypes are related, closely related. You might not get, although you are exposed to another different serotype, you might not get the disease for about, you will be protected for 6 months to 1 year at least. So but after 1 year you can get infected with a different serotype. But there is a concept called primary infection and secondary infection. For us clinicians, it's very important. Primary infection means you are getting infected with one serotype for the first time, right? Any serotype, that is primary infection. Secondary infection means you are already infected with one serotype, you are getting infection from after 1 year or so from a serotype other than you have already got infected. This is very important. Primary infection carries good prognosis. They almost always recover. Secondary infection, they run into problems, but we as doctors should identify the problems and solve the problems. Then they also won't die. But in this day and age, dengue deaths are very rare, right? Okay, because we clinically we cannot differentiate the two. Whether you are having primary infection or secondary infection, clinically you cannot differentiate, right? But you have to follow the patient up, follow up and see how the patient is behaving. If you can follow up and see if the patient is behaving like primary, we know there are no problem. If he behaving as a secondary, then we know what to do, right? Okay, so it is very important to differentiate primary. Primary infection is usually called dengue fever, DF. Secondary infection is called dengue hemorrhagic fever. So if you are having dengue fever, if your doctor says you are having dengue fever, nothing to worry. You are going to recover, right? Okay. If he says you are having dengue hemorrhagic fever, still nothing to worry. Our doctors will look after you, right? Okay. When you get infected, exposed to a dengue infection, after incubation period, majority, about 90% are asymptomatic. They have viremia, is not significant enough to produce symptoms. So they are 90% asymptomatic. Only about 10% will be symptomatic. Symptomatic in the sense fever and other symptoms, right? Okay. Symptomatic patients also has a range of symptoms, range of diseases. On one end, you have a mild infection, viral syndrome, particularly in children exposed for the first time. They don't come to the hospital even 1 or 2 days of fever. It resembles any other viral fever. They don't come to a hospital. Only these two, dengue fever and dengue hemorrhagic fever, are the problems usually they come. But dengue fever, as I said, carries a good prognosis, the EHF, sometimes poor prognosis, right? Okay? But even then, among these two, dengue fever is more common than DHF. So actually nature has been kind enough for us because majority are asymptomatic, even some are getting viral syndrome, insignificant. Only 1% will get this severe form, which is fatal sometimes, right? Expanded dengue syndrome, only 1%. So range of disease, but only these two are the commonest presentation into hospital. So in summary, incubation period after 4 to 15 days, majority are asymptomatic. Symptomatic illness forms a mild range, mild to severe disease. DHF or severe disease is actually DHF. DHF can be cured if diagnosis early and proper management is given. If does not give proper treatment, it can lead to complications and even death. So it is our duty is to look after these patients, diagnose them very early and give the treatment so that they don't develop any complications. They don't die. So a little bit about the dengue fever and dengue hemorrhagic fever. You know, when you are getting infection for the first time, a primary infection, dengue fever, actually both these diseases resemble in the fever periods. They have what you call febrile or fever period and fever settles. During the fever period, you can't distinguish the two. Symptomatology is same. We can't. But when the fever settles, dengue fever patient will improve. Your appetite will return, your passing urine well, quite all right, everything is fine. Dengue hemorrhagic fever won't like that, because he will sometimes be critically ill soon after fever settles, and sometimes you may have to send to the ICU even, right? So they have what you call a critical phase. Soon after fever settles, they have gone into a critical phase, and then if you manage the critical phase properly, then they will recover, like this patient, right? Okay. So we as doctors will have to identify this critical phase. What is happening during this critical phase is actually when the fever settles. Remember, this is the only disease in medical profession where we are worried when the fever settles. All the other diseases, when the fever settles, we are very happy. When the fever settles, the plasma, I mean, due to increased vascular permeability, the plasma goes out into the space, into abdominal cavity and thorax. It is actually it is a selective plasma leak due to increased vascular permeability. You know, through the small inside the blood, you have what you call plasma and red cell, white cell, cellular component, and liquid form. Liquid form. So when the fever settles, the liquid forms leak out into the cavities, not leaking out from the body. Like diarrhea, for example, everything is going out of the body. We have to replace that. Here it's not like that. It goes out into the spaces, body cavities, for temporary. It goes out for a while, for 24 to 48 hours, and comes back also, right? After that, right? So this you have to identify. If you don't identify this, it is not going out of body. It is only to the abdominal cavity and the chest cavity. Nowhere else it leaks. There is no generalized leaking capillaries. Capillaries are leaking only in those two areas. Therefore, if you want to find out whether when the fever settles, if you want to find out whether the fluid are leaking, you have to. The best investigation is actually doing an ultrasound scan. Ultrasound scan of the abdomen and chest. Right? These are the two places where you get fluid. Right? Fluid goes temporarily. It is transient thing. Right? Only for 24 to 48 hours. After that, it comes back. Right? If you manage this patient, when you goes out, the fluid goes out, you have to give a little bit of fluid. You have to identify that and give a little bit of fluid. Give a little push to the patient. Then the patient will recover. Right? After that, at the end of 48 hours, when things are returning, you have to stop giving fluid. If you continue to give fluid, you will get fluid overloaded. Don't give too much fluid. So we know how to give that. So we'll have to identify this phase and manage properly, so that ultimately he will recover. So if you don't identify this, what will happen? Plasma goes out, blood becomes thicker, right? And perfusion to organs fails, and one by one our organs will fail. Liver fails, kidney fails, multi-organ failure. Ultimately people will die of multi-organ. We can prevent that by identifying this and giving a little bit of push, right? Okay. We don't give too much fluid, because we know that fluid which has gone into the abdominal cavity and the lungs, pleural cavity, lungs, ultimately will come back. Therefore, we don't give too much fluid. We give just sufficient fluid to maintain vital signs within normal limits and keep the patient going, and look after this during the critical phase. And after the moment the critical phase is over, we stop. So we should know how to identify the critical phase. We should know what is happening during the critical phase, and at the end of how to identify the end of the critical phase also we should know. We should know all these things. I will just briefly mention all about these things in a little while. Now, Dr. Sudath said, dengue fever and dengue prevention during the fever period, you cannot differentiate. These are the symptoms he told little while ago. But all these features are not there in a country like ours. When we are endemic for dengue, we don't get the full-blown picture. We get only one or two features. Therefore, we have a formula called fever +2 +2 to diagnose in our country, right? That is, among these symptoms, fever is to diagnose dengue, fever is essential. Fever should be there. Apart from that, two of these features he mentioned is good enough. And also, you must, when you do a full blood count, white cell count drops and the platelet count drops. Those two also should be there. So fever plus 2 means this is a mnemonic to diagnose dengue early. Right, when you have these symptoms, at the end of the fever phase, one person is going to recover without evidence of leaking, one will have leaking. We have to identify this, right? Okay, the one is not going to have leaking is DF, is going to recover, right? One is having leaking, plasma leak, he needs some close assistance, right? So it is important to recognize these here, because all the deaths are due to, most of the deaths are due to, not all, most of the deaths are due to DHF in our country. Very rarely you can get deaths due to DF. So it is a question of managing the DHF patients well in order to prevent complications and deaths. So this is the laboratory diagnosis. You know, this is primary infection, this is primary infection, this is secondary infection. It's simple. Then when virus enters, you get a viremia, virus multiplying in blood. That's called viremia. With the viremia, you get NS1 response, NS1 antigen appears. After some time, the antibodies will appear. Antibodies in IgM antibodies appear first, right? Then the IgG appears little later, right? And right, if you are exposed to the second infection, this IgG surge. There will be a surge of IgG, right? So when you are doing the test, we have a test, NS1 antigen test available in our country, right? Good quality test. So the primary infection you can identify by doing NS1, which is present from day 1, maximum on day 3, by day 5 it wanes, right? By day 5, antibodies will appear, IgM will appear, right? So therefore we use sometimes combo test. Sometimes initially you do NS1 test to diagnose, then on the 5th day, 6th day we use a combo test, that is NS1 plus antibodies. It will be positive in either way. I mean, if the maybe NS1 may be negative, but antibodies will be positive, so they can make a diagnosis, right? But remember, this viremia is actually shorter in secondary infection. I said secondary infection is the one which gives DHF, no? But DHF for the clinicians, symptoms of the body aches, fever, body aches, muscle pain, things like that, will be little bit less. DF patient will shout, I'm having this pain, that sort of thing. DHF patients may be bit silent, okay? Because viremia is shorter and small, right? Okay. Anyway, yeah, the diagnosis actually, now patients will come to you at any day. So we can't tell a patient not to come on the first day. They come with fever on the first day. It's very difficult for us to diagnose dengue on the first day. Only thing is he may have a fever only, or maybe few symptoms, right? But that is called suspected dengue. We can suspect dengue because if he is coming from a dengue endemic area or during the monsoons or outbreak, any fever coming from that area is considered as dengue, right? But if you want, you can confirm the dengue by doing an NS1 antigen test, right? It is positive even on the day 1. So confirmation is done by doing a positive, which has a very high sensitivity and specificity, right? Meaning nearly more than 90%. And in fact, WHO pre-qualified, now they have pre-qualified this test as to include in the dengue diagnosis, because it's so important if you want to make an early diagnosis. Why do you want to make an early diagnosis? We want to make an early diagnosis because we want to see whether this patient is behaving as dengue fever or dengue hemorrhagic fever. Only by following up we can say it is so, right? Okay, initially you can't say, but if you know the diagnosis of the fever, then you can be vigilant. You are looking for which way this patient is behaving, Say for instance, if a patient comes in fever and there's you think of a different diagnosis like epileptospirosis, for example, then you don't think of DF/DHF. No? If you know the diagnosis by doing NS1 antigen, which is 90% positive, right? Then you know you can actively look for which way the patient is behaving, whether dengue fever way or dengue hemorrhagic fever. Okay. So, but remember, if although NS1 is positive, it is not 100%. Therefore, if you think if the NS1 is negative, it doesn't exclude dengue. Your clinical diagnosis is more important than in that case, right? Okay. And sometimes when the patient comes little late, we are happy. I mean, in the sense we can make a diagnosis, clinical even. They have a bleeding tendency. They have a full blood count changes in the CBC, full blood count. I will tell you the changes in a little while. The full blood count, then that is called probable dengue. So we have here 3 case scenarios: suspected dengue, probable dengue. But both these conditions can be confirmed by doing NS1 antigen, which is a WHO pre-qualified test at the moment. So in natural history of dengue fever is you have fever 2 to 7 days. Once the fever settles, things will appetite improves, general condition improves, passing urine well, patient is perfectly all right. That is dengue fever. Okay. So how do you manage the fever? Whether initially you can't say whether dengue fever or dengue hemorrhagic fever or no. So you have standard management. Rest. Bed rest is not necessary. Rest at home. Don't participate in strenuous exercises. That is one thing. Don't use muscles too much because muscles involved in this disease, right? Okay. Paracetamol only. Paracetamol, even the correct dose, even a little lower dose is good enough because this disease has a liver involvement. Paracetamol has a liver toxicity. Therefore, we don't recommend the full dose paracetamol. If you can take SOS when necessary, so much the better, right? Okay. And also you must convince the people when you have viremia only you have fever. During the febrile phase you have viremia, right? At the end of the febrile phase when the fever settles, no viremia, right? So if you have fever, I mean even if you give correct dose of paracetamol, the fever might not settle. Fever will take its own time, naturally. So you must tell the fever will subside only with paracetamol, not fully abate, right? Okay. So vomiting you can give these drugs. As things like aspirin and clopidogrel, if you are on these drugs, you have to vomit. And this is the most important thing. Avoid NSAIDs and steroids. Now sometimes the doctors also give NSAIDs to bring down because you demand because this disease has high fever, 38 plus all the time at least. So therefore you demand, doctor, please give me something to bring down the temperature. You give the correct dose of paracetamol, it is not coming down because that is the nature of the disease, right? Okay, you have to understand. But instead of that, you try to give NSAID steroids, right? Then it will induce bleeding, right? So I mean, this disease usually, apart from the fever, myalgia, arthralgia, they have a bleeding tendency, right? But usually in the beginning there is no bleeding in our country. Only there will be little red spots in the skin sometimes, right? But if you give NSAIDs, they will have a lot of bleeding. They will vomit blood, they will pass blood from backside, right? They have bleeding into the gut, and it's terrible. Outcome is terrible, right? Okay. Now fluids we recommend to take at least 1.5 to 2 ml. Nowadays even 3.5 because of the climate, right? Okay. ORS, king coconut water, fruit juices, all nothing but plain. These things are better than plain water. And red or brown drinks are prohibited because when you vomit blood, you have to recognize that, no? Therefore, you don't give any red colored, dark colored stuff. If patients cannot tolerate IV, oral, by mouth, then give it. And sleep under a bed net. This bed net is only during febrile phase. Remember that. Viremia is there only during febrile phase. That is to prevent mosquitoes, non-infected mosquitoes getting infected for the benefit of the others in the society. Not, it won't benefit because mosquitoes won't bite you, all right, but for the benefit of others. I mean, dengue point of view, non-infected mosquitoes bite during the febrile phase, you take blood, they become infected and they go and bite others. It will spread the disease, okay? This is the critical phase. I will just explain to you when they are leaking how it happens, right? Usually when I told you when the temperature drops, this happens, right? Okay. Usually when the temperature of plasma starts leaking into the third space, into the abdominal cavity and pleural cavity, right? Nowhere else. If there is edema in the feet or hand, it is not dengue. Only to these two spaces they leak, plasma leak, right? And that is a steady leak. It won't leak like this. Right. It will slowly leak over and reach as a peak. If there's a critical plasma is leaked, then they go into shock. Right? That is the problem. Right? At the beginning, they don't have any symptoms. When they start leaking, like a dengue fever patient, they are all right. When they really start leaking, gradually going up, this is called ascending limb of leaking, and this is called descending limb of leaking. Gradually going up, gradually coming down, and by 48 hours, everything is over, right? By about 24 hours, if he leaks, they go into shock. That is the problem. They can even come in shock. They have leaked at home, right? Because when they leak for a while, then they develop some symptoms. They are called, for a while, they are called warning signs, which I am going to tell you. Warning signs of shock, impending shock. If you ignore that warning signs, in next moment he will go into shock. Okay? Right. So, but even at the note, when they just started leaking, we can't detect. Nobody can detect. Right? Even the ultrasound scan will be positive after some time he has leaked. Because you need some little bit of fluid for you to see through the ultrasound. But at the 0 point, you can't see. Right? So this is important. So usually we have this thing. Drop in temperature is an indicator. Urine output falls. Urine output, because urine, when the plasma leaks out, urine perfusion is impaired. Therefore urine output drops. And the platelet count, we all know the platelet count in dengue is less than 100,000. When it is crossing the 100,000, that is the time they leak. Usual platelet count is 150,000 to 450,000. But when the platelet count drops below 100,000, that level, when it's crossing, that is the time they start leaking. Okay, so these are useful guide for us. And with the platelet count, the hemoconcentration, the concentration in the blood goes up. And the way to measure it, we have called something like PCV, Paxel volume. Paxel volume is actually indicates hemoconcentration. The Paxel volume goes up. So those are the things we are looking for in order to identify, right? And the other thing, of course, we can do two things. When you have all these things, we can do ultrasound scan and see whether there is any little fluid in the abdomen or chest cavity. If you don't have ultrasound scan, even a general practitioner, bedside you can detect this. Bedside you can ask for the no fever, platelet count, they will bring a full blood count, platelet count closer to 100,000, right? And PCV is also rising by 20% rise, that is the cutoff point. And when they leak, their pulse rate goes up, because when the plasma goes out, the heart pumps, particularly in children, their hearts are healthy. They respond with tachycardia, heart pumps rapidly, right? Therefore, pulse rate goes down. All what you need, when a dengue patient comes to you, question, you have to ask whether you have fever. He said no fever. All these days I had fever, today no fever. Then you are alert. Now is he leaking? Right? All what you have to do is feel the pulse, tachycardia. All right? Okay, then also there is a thing called pulse pressure. Pulse pressure means, right? If you check the blood pressure, you have upper systolic blood pressure 120, diastolic pressure 80. 120 minus 80 is 40. That is the pulse pressure. Now you and I, all the normal people, have a pulse pressure more than 30. These children, the pulse pressure less than 30. It becomes 20, 26, 25. If the pulse pressure is 20, we consider as shock. Right? Pulse pressure is 20. And shock is not like other shocks. Now, shock can be due to various things. Septic shock, you have probably heard. Septic shock are, those patients are, very ill, unconscious. Right? These shock people, they might even walk. Conscious, alert, rational. Right? Okay? That is the difficulty in identifying this shock. Unless you feel the pulse and check the blood pressure, you can identify or shake hand with the patient. Patient is cold. Peripheries are cold, hands are cold. Then only you can realize this fellow is in shock. Okay. And this PCV, I told you, along with the leaking, the PCV also follows. So PCV is a good measurement which we do in our day-to-day practice. Right? Because when the leaking is going up, PCV is also going up. Right? It closely follows. So these what we are doing, and this gentleman is the person, Professor Scott Halstead. He is the man who discovered many things in dengue, right? Leaking, the etiology of leaking and everything. But he is the person who introduced this microhematocrit to our hospitals. In Sri Lanka, our hospitals, each ward has a microhematocrit. So they do PCV every now and then. When you get if you don't have ultrasound, PCV rise is good enough. Right? In adults, PCV rise is more helpful than children. Children, because of the healthy heart, they respond to the fluid leak with tachycardia, right? And, lowering of pulse pressure. But adults won't respond like that. Okay. So the onset of leaking is heralded by, critical phase is heralded by onset of plasma leakage. Platelet count 100,000, below 100,000 is the most useful indicator of leaking. Plasma leakage can cause shock. And if not detected, very often you don't detect because they are normal. Unless you touch the patient, right? You don't detect, right? They will be in prolonged shock by definition. In the state of shock for 4 hours is prolonged shock, and that will lead to bleeding and multi-organ failure, as I told you, and sometimes death, right? We have to prevent that, right? We have to identify leaking first, and then give the little bit of saline. Yeah. This is important. When you leak, at this point, on 0 point, there are no symptoms. Patients are perfect. But when they leak for a while, they develop what you call warning signs. These are the warning signs. They will just say, even a child will say, I am not feeling well. Fever is settled, but after 2 or 3 hours, I am not feeling well. Right? Faintish when getting up, postural giddiness. Right? So many people I have seen, they have fallen on the washroom. They are going to the toilet and washroom fallen. Right? Because these people have leaked for a while. Lethargy, and bleeding tendency. Not passing urine also. Right? So these are called warning signs. And those who are treating should know the signs of shock. Shock is rapid weak pulse without fever. You don't have any business to have tachycardia or rapid pulse without fever. If you have rapid pulse without fever in a dengue patient, you have to think of okay. Anyway, the criteria for admission. These criteria actually, these are the criteria for admission. Actually, these for children less than 150,000. Right. Okay. Shall we do the febrile case management and stop? Right? Okay. This is how you manage this patient. This is the febrile phase, home care. What do you do in the home care and GP care, and then decide on admission and management in the hospital, right? Very briefly, home care, advice on home care, rest, fever control, and some sort of monitoring at home. At least they can do urine output. You can say urine output is reducing, especially towards the end of the febrile phase, right? And the temperature chart they can maintain. When the temperature is settling, you anticipate the worst. Okay? And educate the patient. And always you must discuss with your GP, right, about any problem, because these days you can discuss. I mean, these what I mean, in the facilities we just study people, 72 patients who have died in 2022, and only nearly 64% of the patients did not turn up for any doctor. Right? That is poor. That is poor. Anyway, when they are admitted to the ward, we will have a good monitoring, right? Early detection of clinically, usually plasma leakage occurs during when the fever settles, right? And when the platelet count crosses 100,000 mark, right? And urine output reduces. Okay, I'll rush. I'll just do the this slide. CBC, how to interpret the full blood count. That is important, I think, because in full blood count profile, we have white cells, we have neutrophils, we have lymphocytes, we have PCV or hematocrit, and we have platelet count. Those are the important things in. Now see here, you tabulate according to chronological order. You tabulate the. Usually we do full blood counts regularly, depending on the platelet count, right? At least once a day, sometimes twice a day. Now this patient, they have done from day 3 onwards, sometimes twice a day. You see what will happen. I mean, white cell count gradually drops, and then white cell count going up. Neutrophils gradually drops, and the lymphocyte predominance. Lymphocytes get predominant, and a hematocrit will go up here, and the platelet count crosses 100,000 mark. This is the time they leak. Yeah, this is the time they leak. By tabulating tabulating the available full blood counts, we can see immediately at what time the patient leaks. Right? Okay. So the patient leaks when the white cell count is going up, platelet count is crossing 100,000 mark, and the hematocrit is rising. Right? This is the time patient has leaked. Right? So it is important. We can start treatment at this point of care. So shall I stop then? Yeah, just the final comment. Okay. I don't know. I didn't try. I go to the last slide. Last slide is important. Can you get me the last slide? Get short. Right. At least this one. This is very interesting. The patient condition on admission. We have two kinds of patients, DHF patients. They walk into our hospital, walking in patient, and those are coming in shock. We prefer walking in patient, because shock patient means they have leaked at home for a while. They are going to shock. So we have to educate our patient on shock, features of shock. Don't wait at home too long. Discuss with your GP, right? And admission is important, crucial. That's why in College of Pediatricians has said, when the platelet count drops 150,000 below, admit. That time they are not leaking. To be on the safe side, College of Sri Lanka College of Physicians 130,000, because in adults it is leaking is not that predominant. Leaking and bleeding equally important, but in children leaking is predominant. Therefore, we get them down very early. So walking in patient, they are coming in the febrile phase or in the early leaking phase. Right? But having said that, this is what has happened in the DHF in 60 patient analysis. Patient in 2022, right? We are analyzing. See, they have only, forget about this, they have only 31% of patients come in the febrile phase. Leaking, not in shock, only 51. Others are compensated shock and advanced shock. Advanced shock, they are come. Right? All these patients died. Right? But we have to prevent this. We have to get them down early, some other, right? Okay. I can go on and on. This is another thing, same analysis, right? Who are the people who have died? Young adults, 25 to 30, 51% of young adults, because they are breadwinners. The moment the fever settles, they think everything is all right. They go for work. And at the end of the day, peers bring them to the hospital. They are in shock. Okay? Like these have happened. We have analysis of our deaths. Right? Anyway, I will skip these things. These are with the plasma leak. Risk factors. These are the risk patients. They are more likely to be leaking than others. Elderly patient, infants, pregnancy, obesity, and things like that. Right? Platelet count crossing 100,000 is usually indicate the end of the febrile phase and entry into the critical phase. At least you remember that, because you can look at the full blood count, right? So natural history of the DHF is actually febrile phase followed by critical phase, short critical, and this is stereotypic. It is stereotypic. However short the critical phase is, they might undergo these three phases. Unlike the dengue fever patient, febrile phase, they improve, convalescent phase. Here, febrile phase, critical phase, and the convalescent phase, right? Okay. So they can behave in various ways. I mean, they can peak rapidly, peak moderately, right? And some majority of the patients are mild leakers, right? This is we can identify. Now, my colleague of mine yesterday told me that she is getting a lot of pediatrician colleague. She told me that they are getting mild leakers, lot of mild leakers. They don't come even for treatment. They take little ORS and they are all right. They come because of the low platelet count. Once platelet count is useful only at the 100,000 mark. Well, after that we don't look at the platelet count. Only we look at the platelet count when the patient is improving. If the patient is improving, the platelet count goes up. So in between, the platelet count goes down and then pick up. So our people are worried when the platelet count goes up. They are trying to bring it up, right? They come in a recovery phase. Okay, almost at the recovery phase. Right. Anyway, I just so avoid when our aim is to avoid shock and avoid overload. Right. Okay. I just skip these. Only the last comments I. Okay. This is the recovery. The recovery means this. You should know. End of leaking. You can identify this sort of. They complain of itching. A, B, C, D. A for improved appetite. All this time appetite is poor. Suddenly appetite improves. That is your patient is improving. B means bradycardia. They have bradycardia. They have this convalescent rash. That is red background with white spots. Typical in dengue. If you get this rash, you know the leaking is over. You may have other complications. You have given too much of fluid, you have to get rid of the excess fluid. You may have bleeding inside, you have to manage that. That is a different question. But our aim is to give fluids in such a way that the patient will have uneventful recovery. Okay? So I can't go into details on how to manage. Our doctors are doing very well at the moment. Right? Our case fatality is very low in the whole world. I think we are the best. Right? 0.03% case fatality rate in Sri Lanka. Right? That is very, very low. We have exceeded our target. I mean, target is only 1%, but we have exceeded our target. So we are now heading for zero mortality. Right? Right? So this is the typical causes of death. Actually, I told you that that patients, dengue fever patients, there are a few patients that died. And you know why they have died? They have died of taking NSAIDs, ibuprofen and things like that. They were bleeding.
Thank you, Dr. Weeraman. We are very sorry. There is a time constraint anyway. And I think we can take up the question during the questions and answer time. We can discuss more. Thank you very much. So when the fever settles, the doctors are worried. Why? The patient can be going into a critical phase. So we have to remember that as the lay personnel, I feel. Now let me introduce Dr. Sanath Hettige. I don't think that he needs a very big introduction because most of us know him well. Dr. Sanath Hettige is a consultant in family medicine and holds a degrees of Bachelor of Medicine and Surgery, postgraduate diploma in family medicine, and Doctor of Medicine in Family Medicine from the University of Colombo. He holds the qualification of Fellow of the College of General Practitioners as well. He is an honorary senior lecturer for Faculty of Medicine, University of Colombo, Kothalavala Defence Academy, and the Faculty of Medical Sciences, University of Sri Jayawardhanapura, and he was the former chairperson of the Board of Study in Family Medicine for the Postgraduate Institute of Medicine of University of Colombo. Dr. Hettige is not only a doctor, he is an inventor and a business entrepreneur as well. He is the chairman or the managing director of Oil of the Mergay Group of companies. He is the chief scientist of Oil of the Mergay Laboratories and the Mergay Research Medical Center. He has won several national and international awards for his interventions where he has contributed to the field of medicine, including the Presidential Award for the Best Medical Invention for the year 2013. Dr. Hettige is a life member of College of General Practitioners and he held several positions. He is presently a council member of the Independent Medical Practitioners Association as well. He was the former chairman of the National Issues Committee and the current chairman of the Health and Nutrition Committee of Organization of Professional Association. He is one of the professionals who has been heavily involved in dengue prevention and control in the country. Currently, he holds the position in the National Advisory Committee for Communicable Diseases and was one of the authors for developing the dengue guidelines. President of the OPA, Secretary General of OPA, the distinguished guest, let me invite Dr. Hettige to present his presentation on Protect Yourself from Dengue and what is new. Over to you, Dr. Hettige.
Thank you for that kind introduction. My presentation will be very short. Actually, most of what have to be said about dengue was told by Dr. Sudath Samaraweera and Dr. Jayantha Weeraman. My duty is to explain to you few practical points which is of very important to the general public, for the general population, who are non-doctors. Some very practical points which will be very short, but it will be very important to control the dengue spread in our country and to protect ourselves from dengue. Now, this whole thing is there because mosquitoes are biting us. So if we can protect somehow ourselves from the mosquito bites, whole this thing about dengue will not be there anymore. So but just simple this insect can cause so much of problem. So if we can protect ourselves from dengue, from the mosquito bite, we can do a lot. So one of the most important thing is in our house. If somebody is having dengue, this was told earlier also, I like to emphasize on that, we have to make sure that he is not bitten by mosquitoes and this mosquito doesn't bite the other people in the house. So because we see in one house 2 to 3 people come to us, so it's a big burden for the family where 2 or 3 people in the houses have got infected. So if we could reduce the mosquito density in your house and in your environment, at least when you see that one of your family members have got dengue, we can reduce this type of spread. As it is, if you have a dengue patient, you have to inform the PHI, who will do the fogging and reduce the outside mosquito density. Don't worry, now they won't take you probably to the police station or fine, but they will come and fog and try to reduce the the spread. So if you have a dengue patient in your house, please use a mosquito repellent. There are mosquito repellents which you can use, vaporizers, so that that person may not be bitten, and the spread to the we can reduce the infection of mosquitoes and reduce the incidence that other family members of your house get. But of course, we must understand that there are a lot of asymptomatic infections also, where 70% of people show no symptoms. We may be having dengue and we may be spreading it due to mosquito bites, but we may be not knowing. But protecting ourselves from dengue is very important from the mosquito. For example, now for when we have seminars like this, right, in schools, why don't you put 1 or 2 vaporizers to protect people by biting? These are practical points which we have to do, and that will definitely reduce the spread. So you have to reduce the density in the environment and in your own house. So I told you I will explain how you can protect the mosquito density in your house in a very practical way. Right? The other way is to wear protective clothing, use mosquito repellents, methods to destroy the adult mosquitoes. So actually this everybody knows about this, to stop mosquito breeding places, which was dealt earlier. Sometimes destroying the adult mosquitoes may be more effective than trying to destroy the larvae. Now the world has tried to destroy the larvae breeding places, but it has not succeeded very much. I am not talking about the bio control, but just try to reduce the breeding places of mosquitoes, which is not an easy thing, because even as Dr. Sudath Samaraweera said, even small quantity of is enough to for them to breathe. So we can try to destroy the adult mosquitoes, because from one adult mosquito they can produce about 300 eggs. So you produce about 300 mosquitoes. So fogging and things. Now actually in places like, you can use mosquito bats, like where you can destroy the mosquito before occasion. Now we see in hotels lot of mosquitoes are there. So we must aim at destroying these mosquitoes. Not that it will prevent 100%, but it will have a good impact. Now how could you reduce the mosquito density in your own house? It's a very simple thing, right? Now how does the mosquitoes come to your house? Through the lure. Through the lure only mosquitoes comes into your house. So if you can cover this lure with a simple mesh, your mosquito density in your house decreases. You yourself can do. You don't need, you can just take a small mosquito and glue it around, and immediately you can reduce your mosquito density in your house, and you can protect yourself, and you can protect others also. Now see, you can in this way you can actually you can put this mesh and prevent the mosquitoes coming in, right? And so what we should actually do is, right, when we are building house, we can have a large window, right? A small glass. Now usually this is the type we have, a large window and a small lure. So to get air, we tend to open this window, So what we can do is, instead of this, we have a large lure which is covered with a mosquito protective net and have a small flicked glass. So therefore, the mosquitoes will find it difficult to come in, and your house will be almost free of mosquitoes. So these are the things which you can do actually. And these things actually, what I think is, these should go into architectural plans and considered when giving approval to building plans, to make sure that the lures are covered. So if we just say it won't happen, but if it goes into architectural approval procedure for these things, it will have a long-term effect. The other thing is to ensure that your child wears protective clothing when you are going out, right? How many of us tell our child to wear some socks and clothes and go out? We must emphasize that, especially when you are living in a dengue endemic area, and that will definitely reduce the bite of mosquitoes. So when they are going to play, just tell them to wear some shoes and trousers. So that will protect mosquito bite, and that will reduce the transmission also. I mean, it won't protect 100%, but surely there will be. Now in schools, a lot of girls have to wear uniforms, short uniforms, and I know even prefects say not to put the socks up. That's the way. But actually, if you can put at least the socks up, that will give some sort of protection. Or you can wear leggings or some sort of pants under the uniform to protect at severe endemic time of dengue, right? So now this is the normal way. See, why not wear like this? See, we have shoes, we have leggings. So this will definitely protect this thing, because I know there had been a study done abroad where you put insecticide on school uniforms, and the incidents were reduced. So you don't need to do that, but you can cover them. Here, even boys, make sure that when your child is going out, to wear socks and shoes. These are some practical things. This we know, mosquito vaporizers and things. So that's right. So this one part of my lecture is over. This is I want to tell you practical. And my other duty is to summarize very briefly what Dr. Sudath Samaraweera and Dr. Weeraman has said. Very few things. If you get fever, this is very important in your family. If any one of you all get fever, please think that it is going to be dengue. And if somebody is having fever, dry fever, in my experience, there are two forms of fever we normally can have. Dry fever without no cough and cold. The other one is we have cough and cold and rhinorrhea. Dengue mostly is type of dry fever, because the dengue virus does not multiply in your respiratory system. It generally multiplies in your bone marrow, reticuloendothelial system. So you don't, very rarely, normally you don't get cough and cold. But of course some cases you can have. So if somebody gets fever, dry fever, think that it is dengue and go to your doctor. Not like good olden days where, dengue was not there and you can wait for 2 to 3 days. And my advice, you can tell your colleagues whom you are representative of so many organizations, get fever, don't wait at home. First day itself, go to your general practitioner and sit. They can do a test called NS1 antigen test, and almost 99% you can say whether it's dengue or not. So if you know if it is dengue, then as Dr. Weeraman said, he will know, the doctor will know how to manage. So that's the most important thing. Be aware. And if you are diagnosed with dengue, have bed rest, don't go out. And the most dangerous day is when your fever is subsiding. That is the time your pressure can drop and you can have all the complications. Not like other fevers, when the fever is dropping we are happy. But in dengue it's not that. In dengue, if the fever is dropping, we could be happy and unhappy both. Because sometimes fever drops and you're okay. But sometimes fever drops, but you become bad. Your appetite doesn't improve, you become weak, and that is the time you have to do full blood count and see if your platelets is dropping. Immediately you have to get admitted. And they have actually our doctors have the EPID unit. They have done a lot of things and improved on the management. You can be 99% sure that if you get admitted at the proper time, you can be saved. So it's very important to see that. And you may have to do full blood counts. If you are diagnosed with dengue, you have to do full blood counts almost every day. So you have to go to the doctor and he will tell do, and there will be a fluid restriction and they will tell you how to drink your fluid. So that's important to participate that, and not to take ibuprofen, brufen and these painkillers. This we have, I think, given you a copy of this. Please take this and give photocopies to all the organization which you all are representing, and in your websites, and to follow the guidelines given in this if you get dengue, and that will protect everybody from getting into severe disease. And that's all. Thank you very much for listening.
And what we should not do. So now the floor is open for the questions and answer session. I am sure there will be many questions from our speakers, and the floor is open now.
Presentation, Pakistan was not mentioned, but Pakistan, Nepal, Bhutan, Maldives are close proximity to our country, so don't they have dengue? Then the second question is, I think some time ago from Cuba, some spray was imported. Was that sprayed from the air, or what happened to it? Then the third one is Colombo and Jaffna. You said 4,000, the figures, 4,000 and 3,000, but isn't it relevant with the population? Because Colombo will have a large population. So from, we say 1 lakh, only 4,000 is getting infected. And in dengue, if any mosquito can spread the disease, or only a particular mosquito? Thank you.
Actually, yes, Pakistan also having some sort of high incidence of cases, and I think Dr. Weeraman also has visited once there is a large outbreak for the clinical management advice from Sri Lanka, and who could manage it much better. The thing is that I have told that in our region that we go by the World Health Organization region-wise, and Pakistan belongs to another region, and Sri Lanka and Nepal, Bhutan and 11 countries belongs to the Southeast Asian region. That's why I didn't touch on those, even Malaysia, Philippines, those are the countries that have high incidence of, even Laos, Vietnam, those also have high incidence of cases. Dengue spread by, then another thing is the BTI, there's a one bacteria that are invented by Cuba to reduce the dengue incidence. Yes, the mosquito once they get BTI, that mosquito get destroyed. So there are practical issues when you are using that. One thing is you have to use it very frequently. So every 2 weeks time, as I can remember, that otherwise it will not sustain in the environment. So it has a huge human resource that you have to use, and also a huge cost is there. So because of that, in our country, that in a setting where breeding places are, especially these discrete small containers, it is not so practical. But some countries, they are having that in larger containers, larger water containers and tanks or something like that. Yes, they will be having that useful. But this BTI is available in the open market. The people, community can buy that and use it. Then there is a value in it at the household level to use it. The other thing is the dengue. Mosquito. The mosquito, that's I told that there are two types of mosquitoes, Aedes. That Aedes mosquitoes there are so many, in the Aedes group, there are so many mosquitoes, number of mosquitoes, and out of that Aedes aegypti and Aedes albopictus are the responsible for dengue transmission. Out of those two also, Aedes aegypti is the most important the mosquito that is transmitting the disease. Another thing is the incidence years. When you compare properly what is the disease burden, yes, you have to go by the incident by the population. But here we just go by the number of cases, that is the head count, that is the burden of the case load that is having. So that it gives some sort of indirect idea. So actually that when you are speaking that I think the incidence wise Jaffna is having higher incidence, the population is less rather than in the Kalambu. Yes, that's true.
Sometimes use fogging treatments for the control of mosquitoes. Then how the effectiveness of this fogging treatment and what chemicals are used for this treatment? Sometimes we have seen diesel and Biflex, that kind of chemicals are used for the fogging treatments. Is it effective, and how long will it effect in these, and are there new methods that can be controlled the mosquito disease?
Yeah, in one period of time, the using fogging is the method of control that was available, and even the vehicle-mounted fogging machines are used to for fogging larger areas, believing that it will knock down the mosquitoes and do a good control. But with over the time, with more and more evidences, what has shown, and even the what WHO believes is that the fogging per se has no big impact on the disease transmission. So, but when there are cases, and when there are cluster of cases, and when there is an outbreak that can happen, so there is a, if you respond rapidly with fogging, there is some place to control it and bring down the cases. And for that you have certain type of chemicals, usually that you use pyrethroid containing chemicals for this. And there are several that in our control program we use two types of thing, cypronethrin and cypronethrin and combination of another chemical that we are using it for fogging. Fogging you can use, usually what you use as a vehicle, you use diesel or kerosene oil for that. So that's why that it has a bad odor. But now the evidence is there, even with that you mix with water and spray, the same result can happen. So now we are testing it, and that it has shown that the same result, but still that we are doing some more studies on that. And if it is there, so we will be able to do this fogging with the water. That is the usual spray. But going beyond that, now there is the method, what you call this ultra low volume this spray. That it has usually that when you use that you can't see the fogging like mist type of thing, but still that chemical that is spread over the area, and it has more benefit and or more results it is giving. And to have a better result for the clean knocking down the adult mosquito, the what recommend is in that indoor residual spray. In that case, what you do is you spray it is in the indoor where the mosquitoes are resting. Usually the mosquito rests below 2 meters, the height below 2 meters, mainly under the tables and in the wall, the cloth hangings, the carpet, these curtains, those places. So when you are targeting those places has more result, but it is also very you need more human resources, and it is very cumbersome that to use it. So because of that, there is a plus and minuses in this thing. So that's why that we are looking for more innovative methods that will be more effective and less cumbersome.
Iraqna reported the highest incidence of especially chikungunya and then mosquito-related diseases. So the thing is in that project, this dimension had been because that river got dried up and the water was getting accumulated in the potholes. And so this is the immediate consequence of implementation of the power project. Sorry. So the thing is, this dimension, you medical professionals must emphasize that it has to be incorporated into the environment impact assessment process, whatever they do to approve such projects.
Yes, thank you. I think that it's a very good point. We have not looked into that extent, but still that we know that when there is a construction or something going on, especially that the building constructions also have the same impact. There are so many breeding places, and so because of that we are having so many cases. Even sometimes this construction plants has to close down because so many of the people working there getting infected at the same time. So now that we have come to a level that you can budget, actually you have to budget this pest control or the mosquito control and within their BOQ. So there will be some provision for money, provision will be there in the BOQ for mosquito control. So then it is the responsibility of the contractor to get that money and do the control. So there is then much better control will be there. But actually that your point that into mega projects that look into the that put into the impact assessment of the dengue control or the mosquito control also will be a very point. We will be taking it up. We can take it up in the presidential task force or inter-sectoral coordinating meetings. Thank you very much.
This is a layman question and also an old man's question, because old people think they are gold and gold. My question is, Doctor, now if you take malaria also a vector, you said technical term, I can't remember, vector-borne disease. Then why malaria could be controlled and this cannot be controlled? I mean, this is a layman question. If you know the idea very clearly, then we will have a better understanding, I suppose.
Malaria has a specific treatment, whereas dengue doesn't have. Dengue will have to, it's the fluid therapy. With the malaria, various stages can be controlled with treatment. Whether the treatment is available. There is no treatment, only symptomatic treatment.
My question is, why malaria mosquito is controlled and this...
No, malaria mosquito is not controlled. Malaria disease is controlled.
That's why I said
Rabies mosquito is there, still in our country.
I think I can just give one point. Malaria mosquito is there in our country. We don't have the indigenous malaria cases. That means we don't have our own people are getting malaria. We don't have. But if Sri Lankans are going abroad, going to a endemic country, malaria endemic country, they can bring back the parasite. That's why we have to be very vigilant. Though it is eradicated, eliminated from Sri Lanka, at any time it can be transmitted. So we have to be very vigilant, and the Minister of Health is actually very vigilant and still doing the case notifications and sustaining the program. Thank you.
Why do you recommend only paracetamol for these dengue patients? Why not aspirin and other drugs?
Aspirin can cause bleeding. Aspirin can cause bleeding. Aspirin.
Even Panadol is the same?
No, Panadol is paracetamol. Paracetamol can be.
Paracetamol.
Okay, aspirin, ibuprofen, mefenamic acid, those are contraindicated. We don't give. Because in dengue fever, usually they don't die. But in our study, there are a few patients who have died from dengue fever. Right? I say dengue fever carries a death prognosis. But those patients who died, majority were given aspirin, ibuprofen and mefloquine.
Right.
And dengue, we don't give drugs at all. Bare minimum. All the drugs are, because drugs are metabolized in the liver. It's liver toxic. Dengue affects the liver. First organ to damage the liver. So any drug damaging the liver, we don't give.
It's the way they behave is different from the mosquitoes, so that if you spray the walls of the houses, when they just lie on those walls, they could be destroyed. And that is one reason. The other reason is there is only you don't have 4 strains. I mean, okay, you have some strains, but not like dengue. The people who lives in malaria areas, they become immune. You know, they don't get the disease. But if somebody goes from this area to that area, they get the disease. So there is some sort of development of immunity, and the type of mosquito is different. And that the control of that mosquito was much easier than controlling of the dengue spreading mosquitoes. So that was another reason, I think, why we could control malaria. And there were some prophylactic drugs. So when you take it, you don't get the infection. In dengue, we don't have that. So there are so many things. And of course now there is a good vaccine also for malaria. Because there are no 4 strains.
Thank you.
Yeah, malaria has reached the elimination level in the country as a public health problem. So you go by the microfilaria rate, that is how much of the blood film has become positive. It is very much less, and also reported only in pockets of areas, mainly in the beach line, especially in Gaul area and in the western province area. And that's one thing. There is also limited treatment, so because of that it has come down. But now the problem is most of the immigrant workers that who are coming to the country for employment, that we are detecting more and more cases among them, especially who are coming from the Asian countries, including India. So they are detected at the IOM, the Medical Examination Center, that immigration medical screening center, and they are treated. But there is the risk that it can be go on if you don't keep on controlling and do the surveillance part.
Doctor, thank you for sharing us valuable information today. Just want to see that in the BOQ construction site, under the preliminary, we have some amount for the dengue, safety for the dengue and those things. But the contractor may be more to save that something, maybe they are Chinese or they don't have risk of dengue. So I just want to know, in that case, what are the legal action, maximum maybe, what are the legal action can be taken, and the PHI, what is the limitation? Maybe one larva can hold. What is the maximum legal action, and how many, one piece of larva maybe at site he can take the legal? What is the limitation of the PHI and the legal action?
If that area has, if the premises has shown that the breeding of the mosquitoes, that means the larva is positive, that you can have, there is no limitation like that, that even one larva is there, that means that it is the breeding site is there. So you can have that implement the legal action. But in public health point of view, we don't straightly go into the legal actions. We want to promote the people to adhere to the public health practices more and more. So because of that, usually what the PHI or even our public health officers do is they advise them and guide them to reduce that eliminate these breeding places. But if they keep on maintaining these breeding places repeatedly, so then our people go into the legal action. That's how we do, and we don't even you are identified one larvae at the first visit that you don't do anything. Anything means that you do the promotion to reduce that. That's how you go. But some person is keep it on that you like the legal action. That's how we do.
Doctor, I have a question, doctor. Connected to the question that was asked, I am in my profession. See, you can impose a fine. For example, you put that in the POQ and ensure that the particular contractor some bills of buying those chemicals or whatever, and he has done his part. And in case he has not done it properly, then you impose a fine on him. So that carries wrong, but I think it's nice seminar for sure. Respond to you that I have two questions. One is I am a person after bone marrow transplant into multiple myeloma in 2017, and in the year 2023 I encountered dengue. And then of course I managed to overcome that also. Now, how frequently have I got to do these tests again? Will I get dengue again? Now, what some people told me was that in case you have got dengue and if you get it the second time, it might be disastrous. I do not know whether it's true or false. And also about this fogging. Now, many people tell me now they have stopped fogging, especially in the outdoors, because what happens is mosquitoes go and settle in trees and shrubs and various things, and if you start fogging it outside, those mosquitoes go into the house. So then that is also now stopped. And now from an architect's point of view, we even eliminate gutters and downpipes, because in buildings, especially in school buildings, no more that we use gutters and downpipes and even open drains for that reason. So, and also the timings of the dengue mosquito, whether the windows and things should be kept closed or open. So these are my questions. Thank you.
Don't know whether you have some dengue fever or dengue hemorrhage. What is the diagnosis card says? Primary infection. So you can, although you are immunocompromised, but you are an immunocompromised person, so you can get, it's dangerous to get dengue fever again, If you get another attack, you might get dengue hemorrhagic fever. So you have to be careful. There's no other way. Living in this country, you might or might not get the fever up.
What you can do is, you can actually check your blood and see whether you are immune to how many strains. Say you would have got some subclinical attacks. So you have 4 strains. So you can take the immunoglobulin levels, which is not done in most of the labs. I know Sri Jagadhanapura University they do. You can see whether you are immune to dengue. For how many strains you are immune. So if you are lucky, if you are immune to all 4 strains. But so you can do that test in the population and see whether you are immune to dengue. So one thing what you can do is you can see, and probably you may be able to get one of these vaccines. Certain things are not available in this country. Maybe you can get a vaccine which depending on if you have immunity to if you have got flu, and then there are some vaccines which you may be able to get.
Is there a way to identify dengue mosquitoes from other mosquitoes by visual way or physical ways? Number one question, and the other one is we heard that dengue mosquitoes lays in clean water, not in dirty water. Is there a truth in that sense?
Yeah, usually it's a dengue mosquito is a small mosquito, that relatively small mosquito that bites you day to day. Other thing is it has stripes, black and white stripes. So those are the naked eye that thing that you can identify or differentiate dengue mosquito from other mosquitoes. But there are some nuisance mosquitoes also having these black and white stripes, but those are larger mosquitoes. This is a small mosquito. That's one thing. The other thing is that other question you ask is, yes, they breed in clear water, not clean, that's a clear water, that's a less organic matter. So I told that, but if it is not available, they will go for other mode of waters also sometimes. So they are very adaptive. So for example, one thing is there's a brackish water, that's what you call this salty water. That earlier that we thought that is not breeding in salty water, but now that we have evidence that they are breeding in salty water, especially in the Jaffna Peninsula, that we have come across that, because that is the water that is available. Now they are getting adapted to that environment. So it is very hard thing to fight with this mosquito. So you have to be very vigilant, and also that's what I told, that we have to do that continuous monitoring of the mosquito behavior that we have to do, and we have to adapt our control measures accordingly.
Yeah, so it's very hard to fight with the mosquitoes, so we have to be very careful. So I think that comes to the end of our questions and answer session. We may be having a lot of questions, but there is a time limitation. May I now cordially invite Mr. Sanath Hettige, the President of Organization of Professional Association, to award the token of appreciation for our guest speakers. Then can I invite Dr. Sudath Samaraweera to come forward? Thank you very much. Close to the end of this seminar. However, it will not be completed without proposing the vote of thanks. May I now cordially invite Mr. Tisaradi Silva, General Secretary of the Organization for Professional Association, to propose the vote of thanks.
President Mr. Sarath Gamage, President-elect Mr. Sujivalal Dahanayaka, Treasurer Mr. Ruchira Pereira, past presidents, office bearers, expert guest speakers, ladies and gentlemen. We have just concluded a very important seminar on new trends in the prevention and treatment of dengue, organized by the Health and Nutrition Committee of the Organization of Professional Associations. As the country is on a cusp of another dengue epidemic, I am sure that what we have learned today will be of great benefit to all of us, particularly in terms of the practical steps we can all take to control the spread of dengue. I would like to extend my sincere appreciation to Dr. Sudath Samaraweera, Director Dengue Control Program and Consultant Community Physician. Thank you, sir, for your lecture. And then I would like to thank Dr. Jayantha Weeraman, Consultant Pediatrician, and Dr. Sanath Hettige, Consultant Family Medicines and Chairman of the OPA Health and Nutrition Committee, for being our guest speakers this evening. So thank you also goes to Dr. Kanthi Ariyaratne, Convener of the Health and Nutrition Committee, for moderating this seminar. Thank you, ma'am. We have all learned a great deal from your insights and expertise. I would like to express my gratitude to President Mr. Sarath Gamage for his leadership in organizing this event. My appreciation goes to President-elect Mr. Sujivalal Dahanayaka and Mr. Ruchira Pereira, Treasurer of OPA, for their assistance and guidance. A special thank you goes to Dr. Sanath Hettige once again, Chairman of the Health and Nutrition Committee, for his efforts in organizing this seminar. I also must thank the Center Director and staff of OPA for all the assistance provided. Finally, I would like to thank the audience for their active participation, and I would like to now invite everyone for dinner at the OPA restaurant. Thank you.